We are all familiar with vascular factors and melasma because most of our patients will have a little bit of reddish hue when you look at the melasma lesions. And if you look under the microscope, you can see a proliferation of blood vessels within the lesion. So we know that melanocyte responds to endogenic factor, and that the vascular, the vessels produces endothelin, which then acts on the melanocytes. Okay. So we can then target this factor by targeting the microvasculature, either using oral transaminase acid or by using energy-based devices that targets the vessels. If you look at your patients with melasma, you find that a lot of them actually have the lesions on the cheeks and on the forehead, where there are areas rich in sebaceous glands. So we know that sebaceous glands also play a role in the formation of melasma. We know that sebaceous glands secrete cytokines and growth factors which induce melanogenesis. And sebocytes are also under the control of alpha MSH. And we know that alpha MSH increases on UV exposure. Okay? So we can then treat melasma by targeting the sebocytes, either by using energy-based devices or by using the PEP modulation. But this is, I think, is under experimental studies. There's no topical agents yet.
Joyce, it's interesting about the sebocytes. But from my personal observation, right, I hardly see, not that I hardly see, but rarely see those patients that comes to me, right, for melasma also has a lot of acne, very oily skin. A lot of times they are more dry skin. What would be your experience? What is your observation?
You mean that your patient with melasma has drier skin than oily skin?
Yeah. A lot of times, I mean, if this both sides, I hardly see combination of a patient like sebaceous hyperplasia with a lot of melasma or this.
Skin barrier. From a skin barrier perspective, actually, our research and some together with some from, I think another one from US, shows that the lesional skin of melasma actually has got reduced barrier compared to the non-lesional skin, which is interesting too. Yeah.
Okay. I'm Dr. Lee from Korea, and I will speak about the laser part of among the failed case. As many doctors experienced, we can meet many different types of melasma in every day, very different cases. And then sometimes they are often combined with some other pigmentation producing disease, and it's not always easy to treat. Sometimes it can be failed. And the failed case is not uncommon. So what's the cause of fail in melasma? It's probably too much treatment and too strong treatment. And then if you meet some difficult subtypes and difficult skin types, and the combination with underlying the photo damages and improperly applied device can make a failed case. So most of the laser treatment is targeting melanosome areas, and like QCH laser toning and the picosecond laser, and also fractional lasers targeting epidermal replacement. But sometimes it makes some failed case, so we need another treatment method. So another treatment method to change the condition, we should reorganize treatment schedule, and we should treat another laser systems like dermal rejuvenation lasers. There are many different energy-based devices and lasers which can make dermal rejuvenation. And also, as Joyce explained, blood vessel treatment can change the melasma, to change the vascular.
So what about direct access? What kind of cases are good? So ENT emergencies are not good, but what is good would be semi-urgent cases where you cannot get an early enough clinic point. So a good example would be if you suspect your patient has cancer and the book clinic appointment is not.
I think there is a cross Zoom line going on. There's someone speaking at another webinar.
Yeah. No mind. I think I managed to unmute him already.
Okay.
Yeah, we can proceed.